Sí, falta un poco más. No, todavía faltan 2 minutos. 3.
Buenas tardes a todas y todos,
Good
bienvenidos.
afternoon to all and welcome. We're very happy to have you with us. This will be a conversation held in Spanish and English. For those of you who wish to listen to Spanish, you will see the world icon where you can share, where you can choose your language.
This is going to be a conversation in Spanish and English. For those of you who wish to listen to this presentation in English, you will find an icon on your screen in the toolbar that says interpretation. If you click on this icon, you will have the option to choose English. Mi nombre es Pablo Ibarrarán, soy jefe de la División de Salud y
My
Protección
name
Social.
is Pablo Ibarrarán. I am the head of the Division of Social Protection and Health. We will talk about the impact of aging in the population, technology, and public policy in health expenditure. We have top-notch guests that I will introduce to you. There will be a very brief presentation of the various scenarios, and then we will listen to a panel that will deal with questions and answers. First of all, I would like to give Fernando Relivi the floor. Thank you so much, Pablo, and good morning to all of you. Thank you so much for being with us. Today, we will talk of one of the great priorities for our Vision 2025, which is health. From the bank, we focus on the economic recovery of Latin America and the Caribbean. We know that without health, there would not be any recovery. So this is why these conversations are so important. In our previous seminar a few weeks ago with John Hopkins, we saw how the forecasting of expenditure in health is growing. Aging, chronic illness, new technologies, time passes. This is something unavoidable, but the future can be molded, and it depends on what we do today. What happens, for example, if we reduce the use of cigarettes or we improve our diet? Can we have better investments that provide better returns? Can we be more efficient? And in this sense, we will be talking about all these topics, about policies that can improve our future. I will give the mic back to Pablo Ibarrarán, because as he introduced himself, he's the chief of the Division for Social Protection and Health. But before that, I wish to thank Krishna, Andres, and the entire team of researchers and our team in this area for the very important work that they've done to inform on the future policies to improve the health of citizens in Latin America and the Caribbean. Thank you so much. You have the floor, Pablo. Thank you once again, Fernando. The IDB asked the Public Health School, Bloomberg, at the Johns Hopkins University, a study on the projection of health coverage about 3 years ago. In collaboration with teams from 7 countries, they developed a model in order to project the costs for future healthcare based on the trends, based on the profile of illnesses, economic growth, technological progress, and demographic changes in the region. Part of this team will give us a brief presentation of their study, and after that, we will have a very interesting panel that will talk about this. We also have Krishna Rao today, who is an associate professor at the Department of International Health and the Center of Global Health from this university, Andres Vecino, who's an economist in health and associate researcher at the same department. Before we continue, I would like the participants to send their questions through their question and answer icon, which is in the toolbar on the bottom. Without further ado, we'd like to give the floor to Andres and Krishna from Johns Hopkins. Thank you so much.
Am I audible?
Yes.
Okay. Good morning, good afternoon, everyone. It's a great pleasure to present our study, The Future of Health Spending in Latin American Caribbean, to all of you. I'd like to first acknowledge several of my colleagues who were deeply involved in this study. Andres is here with us today. There's Tim Robertson, Caitlin Noonan, Angelica Lopez Hernandez. We also had several researchers from 7 institutions in the Latin America region and from the Caribbean too. So this was quite an international and regional coming together of researchers to answer this very important question of what would health expenditures in the future look like for Latin American and Caribbean countries. When we talk about health expenditures, we're talking in terms of current health expenditures. So these exclude investments in capital goods. The second question that we try to answer in this study is modifying NCD risk factors, what kind of effect will they have on the growth of current health expenditures? And Andres will talk to us about that in more detail. And the third question that we try to answer is what sort of effects will controlling healthcare costs have on the future of health expenditure growth in this region. I'll quickly go over the basic idea behind our model. So from about 7 countries in the Latin American Caribbean region, that is from Mexico, Costa Rica, Argentina, Brazil, Peru, Colombia, Trinidad, and Tobago, we sourced baseline data on age and disease expenditures, right, for 2018, 2019. That was our baseline. So these expenditures were disaggregated by age and disease group. And then we developed a model that would show us how these expenditures by age and disease group would increase due to population growth, population aging, changes in the prevalence of disease, economic growth, and technology. Now, these factors that I have listed here are from the literature, the main sort of drivers of healthcare spending. And then so by combining these factors for each of these countries, as this figure on the right shows, we were able to project what health expenditures would look like in the future, that is, and we projected up to 2050. We also extrapolated from these 7 index countries to other countries in the region. And we did this by grouping countries in terms of their per capita health spending, and then use the age expenditure profiles of these 7 index countries and applied that to the whole group. And on the basis of that, this extrapolation was done. So some initial results. So we projected that the average annual per capita current health expenditure growth rate from 2018 to 2015 is about 3.2% for Latin American countries on the whole, and about 2.4% for Caribbean countries. In Latin America, relatively high, that is more than 3.4% growth between 2030 and 2050 is projected for countries like Panama, Peru, Nicaragua, Chile, Costa Rica, Bolivia, Colombia, and Guatemala. In the Caribbean, high growth, and that in here high growth we've defined as greater than 3.3% a year, was observed in the Dominican Republic and Trinidad and Tobago. Of course, these growth rates, as you can see, vary by country and region. In some countries, they're lower than the historical growth rates. The historical growth rates are in dark blue. In other countries, they're higher than the projected growth rates are higher than the historical growth rates. So as I mentioned earlier, we had projected current health expenditures in the LAC region based on changes in economic growth, technology, population growth, and the age structure of the population, and also disease prevalence. And so one key question to ask is, of these different factors, what is the main driver of health expenditure growth? And as you can see from this table here, the main factor that was driving health expenditure growth was economic growth and technology. So by itself, it increased current health expenditures between baseline in 2015 by 1.78 times in Latin American countries and about 2.96 times in the Caribbean countries. Of course, this is an average, and this will of course vary from between countries in the region. So economic growth and technology had the largest effect on increasing current health expenditures. As I said, it nearly doubled CHE in Latin American countries and nearly increased it by 3 times in the Caribbean countries, right? The contribution of only population growth and aging was quite modest in comparison to economic growth and technology. And so another point to keep in mind is that these effects, as I said, vary by country, and there were some countries where indeed population growth, for example, I think it was Mexico, had a greater effect than economic growth. In all of our countries, we found that the change in disease prevalence by itself had very minute effects on the growth of current health expenditures. Finally, when we look at how the distribution of growth changes between baseline and 2050 by disease and age group, what we found is that in these disease groups listed here, and these are the ICD-10 disease groups, we see high growth rates over time coming from neoplasms, endocrine and nutritional and metabolic diseases, diseases of the eye and endexia, disease of the circulatory system, and so forth. And by age group, the high growth rates are coming from age groups above 70 plus years. So given this, what can be done to reduce or to bend the expenditure curve? And so we present here two sort of scenarios, or two broad scenarios that we looked at. One is cost containment policies, and the other is change in the disease risk factors on non-communicable diseases. So we looked at 4 risk factors, that is tobacco use, hypertension, high blood glucose, alcohol use, and we examined how this would affect disease prevalence and expenditure on diseases related to cancer, diabetes, kidney failure, cardiovascular disease, COPD. So in our results with the cost control, and I'll talk a bit about how we came to this. So to generate the cost control scenario, we assumed that over a 10-year period, LAC countries will be able to achieve cost control on health expenditures. We operationalized this by applying income elasticities of Western European and high-income countries to this calculator, and therefore we could then estimate what might be the effect of cost control strategies. And we use these elasticities because we assume that these countries, and that's borne out by the literature, are able to achieve better cost control than others. So we see that the greatest reductions in cost control would be achieved in many of these countries, as you can see in this chart here. Overall, about 10% in all of these countries. But in 3 countries, the reductions, we see reductions of over about 20%, which is quite substantial. And these reductions are between baseline and 2050. Okay. With that, let me hand it over to you, Andres.
Sure, thank you so much. I'm going to speak in Spanish, so please make sure to select the right interpretation button for you. Para mostrarles un poco.
I wanted to show you how we conducted this exercise. You can see 4 risk factors that we spoke about in the case of tobacco. First of all, we used data that came from the study of the disease to see what is the rate of this disease that can be attributed to all of these risk factors that would produce some of these conditions: the cardiovascular, mellitus, diabetes, kidney failure, and cancer. Taking all of these percentages per country and age groups, what we were able to do was to evaluate and assess how we could extrapolate those relative disease charges toward the chapters ICD 10. And we used data from Colombia, where we could see the participation in expenditure of these 5 conditions in each chapter of ICD. For instance, for the cardiovascular diseases, this was 90% of expenditure. In chapter 9 for diabetes, and for chronic disease, pulmonary degrees, it was 25% within chapter 4, respectively. So of course, cancer is a chapter in itself, and so we use total cost in this sense. And having done this, we went to a shared risk assessment to see what was the potential effect to reduce these risk factors in total expenditure, health expenditure for these 5 conditions in time and by age and country, of course. Let's go on to the next. Here are the results. We found that for the case of tobacco, we saw an outlier, and this is the extreme case of Brazil. And we can see how Brazil is particularly important in order to reduce this disease, reducing costs in the measures to reduce tobacco use. We also found that countries with more tobacco use, we see both of these dimensions. Here we can see Uruguay and Argentina, Paraguay as well. And we also found that this is a risk factor that in general, we know how to treat, and we know how to implement the framework convention. We know that there's taxation and other measures that can reduce tobacco use. So we saw that there was a moderate reduction of use in use of tobacco in time. Next slide, please. Now, in the case of the hypertension, we can see in general terms of what the most important risk factor in order to reduce expenditure in most of these countries. There's less variability through the countries, across the countries. In general, this is a measure that we hope would produce homogeneous results, but in general, it's a difficult point to treat, because aside from the interventions, for instance, curtailing sodium, it's very difficult to treat hypertension. In general, there is secondary hypertension where we can reduce expenditure and reduce the charge of this disease due to high risk. Next slide, please. In the next risk factor, which is high blood glucose in the blood, we're talking specifically about diabetes, the countries that benefit the most from this are Mexico and the countries in the Caribbean. In general, we see a great variability of this effect through the various countries, with a potential high effect in the reduction of this disease and health expenditure. But at the same way, high blood glucose is very difficult to treat, like hypertension in primary care. We don't have much information in this sense. So secondary care is fundamental treatment for all of the complications that might arise. In that sense, all of the work that has been done and that has been planned to reduce fragmentation and strengthening primary care are very important for these 2 risk factors that are so important. Next slide. And in terms of risk factors related to alcohol, this is the one with the least number of effects estimated in terms of the disease and expenditure. Maybe there is an exception, which is Brazil, but the other risk factors seem to have a greater impact in Brazil than in terms of the measures to reduce alcohol. So alcohol and tobacco are risk factors that can be treated relatively easily. There's taxation, and this contributes to the reduction of consumption. But we should point out that in general, this risk factor doesn't have such an important impact as the other risk factors in this region. Let's go on now to the next slide. So keeping in mind this landscape, you can see that there are potential policies that can be implemented in order to face this increase of health expenditure. There are three great dimensions: a better containment of costs, we believe, and we believe the two aspects that the IDB has been in charge of in the region is the strengthening health facilities and the explicit plans for health benefits. This is something that can definitely reduce costs, contain costs, with the changes that would be implemented to improve the quality of the attention and the care that is provided, because these would be technologies that are cost efficient. Another important topic to notice is being able to find alternative resources, sources of resources. An example, for example, are the implementation of taxation on tobacco and alcohol, and those and junk food. These are measures that have been done widely in this region that can provide an alternative source of resources. And the development of health systems that involve digital health and computer systems. I think that this has become very evident with the pandemic, so that we could reduce fragmentation and we could strengthen primary care. So basically, on behalf of the Johns Hopkins team, this is it. Thank you kindly to all of the countries that contributed to the study, as well as the teams of the countries that helped us by being able to find these, acquiring this data. Thank you so much for your attention. Thank you so much, Krishna and Andres, for this excellent presentation, for giving us this landscape and the main results that were able to be found. And this way we can start our discussion with the panel. I want to introduce Marta Ruiz Arant. She is one of the main counselors for IT for Haiti, Mexico, and Dominican Republic. She's worked in the bank. She has a great knowledge of the region. Adolfo Rubenstein, Dr. Rubenstein works in implementation of health policies. He's the ex-Minister of Health in Argentina. Welcome, both of you. I know that we will have an excellent exchange with them. I would also like to remind the participants to send their questions and answers through the icon. While we wait for the questions, we will start with the questions that I have here. The first one will be directed to Dr. Rubenstein. We saw that the reduction of risk factors, chronic disease, is beneficial for all of us because there's better health, and this means that there is less expenditure. And we also saw the great impact of improving efficiencies and containing costs. So these are objectives that are reasonable from the perspective and experience of public policy. What is the best way in which countries can improve health and contain expenditure at the same time? Thank you so much. Thank you, Pablo. And it's truly an honor for me to be able to take part in this panel discussion. I would like to thank the IDB for inviting me. I also wish to say hello to Fernando Regalia and all of you with whom I have worked with over the years on various projects. And to answer your question, and of course, I also wanted to congratulate the Johns Hopkins team, because this is a very exhaustive and detailed study, a very interesting one from my perspective, both as a researcher as well as based on the experience that I had at the Ministry for Health in Argentina. Basically, the first thing that you have to keep in mind in order to reduce health expenditure is how this would be able to impact with the reducing risk factors in chronic disease. It's very important because many Latin American countries, especially those of the southernmost area, have advanced in the epidemiological and demographic advancement, the all of those diseases that are non-communicable and so on. So I think that if we can tackle all of these components of coverage is vital in this sense in order to produce a theory that would be able to bring down health costs. There's another reason. There's an important difference within the countries of Latin America. There are countries that have a greater mortality rate due to chronic disease, as opposed to the richer countries that have market economies. I think that the most important factor is premature death, which affects this, not so much the prevalence or the incidence of chronic disease that are not so different in those countries that have done that demographic and epidemiological exercise. For instance, the countries in the southernmost cone of Latin America, the difference isn't that important, but the age is important to take into account when these events that produce death or disability. And many times these are the productive years of life. So the reduction of this epidemiological phenomenon is very important within health policies, and the impact on lessening costs could have an impact on productivity, on the economic features of the country, on income, so that we can go to a universal coverage. Now, the topic in and of itself is that most of the countries in Latin America and the Caribbean are very far from prioritizing non-communicable chronic disease. So here we have fiscal policies against the use of tobacco, or those that are being used in the case of junk food with those labels that explain what is being eaten, but this has not impacted the total outcome on disability and death. So what we're trying to do is to try to evaluate the impact in the reduction of health expenditure as the product of reducing chronic disease. And this could be one of the limitations that the study has seen. And the authors, what they're trying to do is to try to figure out the independent effect that demographic effects and epidemiological effects on the effects that there is a greater income per capita, technology, and policies on the growth of health expenditure in the next decades. This is also very difficult to achieve, because if you consider this from a more systemic perspective, the demographic and epidemiological transition leads to a greater prevalence of chronic non-communicable diseases, more comorbidity, more use of technologies, a greater intensive use of technologies, and as a consequence, a greater expenditure in health. So this would be a counterpoint to some of the assumptions that are contained in the study. So what could be the impact of the reduction of risk factors on health expenditure? This is an interesting analysis, but I said this a few minutes ago. Basically, I doubt that reduction can be linear as is supposed in the study, and also to answer to the best ways in which the countries in our region can improve health. Well, they contain costs, and at the same time, as I was saying, they provide that greater fiscal space in order to have effective coverage. The authors, in actual fact, said this, our colleagues said this, basically, all this has to do with starting to define more explicitly the services that are covered, the benefits packages. Most of the countries are making progress in the sense the policies of the prices of coverage, technology of medication, because obviously the others are concentrating on technological innovation that lead to improvements in life expectancy at costs that are becoming unsustainable for health systems, so that the regulation of price for, we're not only talking about costs, we're talking about prices, and the regulation of the various agencies, technological agencies, as is happening in many countries of the region.
Additionally, different payment modes for service providers, changing payment systems to other models, performance payment and other models that are starting to expand and scale up in a number of countries. The development of systems that focus on primary care. And we're trying to get away from these hospital-centric models that have predominated in most countries. And we've seen an improvement, a significant improvement in IT systems that have allowed for the improvement in the care provided to patients. Thank you very much. Thank you very much, Adolfo, for your answer. Very key points, those that you mentioned, and we'd like to go back to Krishna and Andres to look at these methodological elements that you mentioned. Question for Marta. We see that in this study, it indicates that the current health expenditure will grow 2 to 3% in Latin America and up to 4% in the Caribbean countries. From your perspective, do you think that these estimates are surprising? Do you think that the region or these regions have the capacity to withstand the added expense? Well, thank you very much, Pablo. First and foremost, good afternoon to everyone. It's an honor to join you here today. And I'd like to join my colleagues in congratulating the Johns Hopkins team for their study. It's hard to come up with accurate forecasts in this regard, but the results are not surprising. I think that there's no doubt that the current health expenditures will continue their growth trend in a very strong way. And as the study found, in many countries, it'll be trending much higher than economic growth. There are certain regions, including Central America, where the expenditures in health are relatively low. I think that the pandemic demonstrated how ill-prepared we were to address this health crisis. As the doctor mentioned, we are not far removed from the goal of achieving universal health care coverage, and this will require more investment in the future. Thirdly, health services are by and large deemed to be low quality services. So these will require important improvement and investment in the coming years. And lastly, as the study points out, there are many pressures from many fronts, and these include demographic elements and epidemiological elements, and a key element is economic growth. In some parts of the region, countries will achieve a GDP level of advanced economies. And what we've seen in the last 6 to 7 decades in the more advanced countries is an example of what we could expect for our region. We've seen accelerated growth in our current health expenditures. We've also seen a growth in the per capita income, and this is a normal phenomenon that stems from normal economic development. As people increase their acquisition power, we can then move to a better system. And this happens with other goods such as education. So these trends really pose very challenging issues. And one of the key elements relates to financial and fiscal sustainability for economic systems. Now, as part of the overall management process, the health sector is key, but as we all know, the makeup of all of our countries is rather complex. The public debt has increased enormously due to the COVID pandemic, and resources are limited. Now, demands have been on the rise, not just in health, but education, public initiatives, measures to reactivate the economy, and other things that we are experiencing at the present time. So as it was stated previously, this will require a prioritization process, an effort to look for efficiencies wherever they can be found. And it also will be necessary not only to identify efficiencies or rather inefficiencies within as well as without or outside the health sector. I think that we've discussed some of these measures, and some of you are better qualified than I am to assess them, but we do need to improve management systems in all sectors, service provision, procurement of medical goods and services, training of human capital, improving hospital facilities. But another important factor relates to a reduction in the fragmentation of health systems. Many countries have a great deal of multiplicity in institutions and their health financing systems, and there are many inequities that are inherent in some of these systems, as well as other perverse elements. So these are solutions for the health sector, but we've also documented some public policy actions that can be undertaken outside of the health sector. There was mention of a few such as regulations or taxes to reduce these risk factors that lead to these chronic diseases. And these include tobacco taxes, alcohol taxes, but there are other initiatives that could be very effective, such as smoking prohibitions and what have you. Awareness is always going to be important, especially in the educational sector, campaigns directed at students and young children in schools to stay away from tobacco. And lastly, there's been a very strong effort to try to reduce the inefficiencies in all these systems. At the IDB, we've noticed that there are many significant inefficiencies in procurement processes for governments. There are social programs that are not properly focused, subsidies that are not managed efficiently. So it's necessary for us to see a liberation of resources and greater allocation to these elements to first and foremost, redirect and reallocate more funding to the health sector to make improvements in a cross-cutting way. And at the same time, undertake initiatives to contain the increasing health expenditures. One of the tasks in the region is the struggle against fiscal inefficiencies. We're trying to work on projects to increase the efficiency of fiscal systems to increase revenue for countries. So I think that all of these sectors require attention and as part of the recovery, and these will be contributing factors to this issue that we have at hand. Thank you for your answer, Marta. I remind all participants that we have this Q&A session now, and you can submit your questions through the chat. Dr. Rubenstein, based on the progress that we've seen with regard to universal health coverage, we've also seen that the study indicates more or less an idea of what the cost would be for this goal. Do you believe that these estimates are correct, or how would you advise a government that has committed to undertaking this process to be able to deal with the increasing costs? Well, thank you for your question. I think first and foremost, it's important to distinguish nominal universal health care from actual effective universal health care coverage. In Argentina 2 years ago, the most ambitious objective that we had was to expand effective coverage for the health sector. And for example, in Argentina, when we talk about nominal universal health care, 100% of the population has a right to access all of the services offered in the public sector, but that doesn't mean that this nominal coverage can then be translated into actual coverage on the ground. So it's important for us to try to really identify this dimension. There are many studies conducted by the World Bank um, and other institutions, and the Hopkins team used some of the information provided by those studies to try to dimensionalize this element, but it's very difficult to achieve. And I think that beyond the epidemiological forecast that are based on disease burden studies and other projections, I would say that nonetheless, notwithstanding the fact that it's an important input to come up with an accurate estimate, I think that the presence of data is much better than the absence of data, but it's very difficult to dimensionalize this effective coverage parameter. When we see this direct relationship or linearity between the increase in expenditures and improved services, I still see as problematic. In some countries, they want to go from 80% coverage to 90% coverage, and that's a lot harder than going from 40 to 50, because the other thing related to universal health care is that there are very different paths that you can embark on. If you choose the softest path, we could then focus on communicable diseases. We can try and improve conditions that favor higher rates of infant mortality. But when you start moving towards chronic NCDs, which are factors undertaken in the study, we clearly have a much more difficult, more complex situations. There are behavioral issues that are in play at different levels within the health system between health professionals, decision makers, and there was also mention of very high institutional fragmentation in all of the systems in the countries in the region. So going from 80 to 90% effective coverage requires a great deal more investment than going from 40% to 50%. And that's why, as the study clearly shows, the elasticity in the increase to revenue is much less impactful in the richer countries in the region and who have managed to achieve some progress with effective coverage. For the LEC countries to achieve these levels of coverage will be very difficult, especially in the face of the ever-growing expenditures that have been reduced by the use of technology. Another factor is that when innovation in technology is not made available to all of the population in one country, because many times there's insufficient fiscal space to achieve that, this leads to opening or widening in the access gap for many people. So to be able to achieve an effective coverage level of 90%, which is typically the goal that will allow us to assess what the impact would be for these projections, then we need to focus on cost containment policies. But as the question alluded to earlier, we need to have a sustainable system because you need to create this necessary fiscal space to be able to undertake these reforms in the system. Thank you, Adolfo. Lastly, another question for Marta before we go to the questions from our participants. Marta, I'll ask you to be as brief as possible so we can move to some of the questions in the chat room. Given your experience and the fact that the COVID-19 pandemic expanded the inequality and the poverty that was already a key concern for the region, from your perspective, what can be done from a public policy standpoint to ensure that health systems contribute to the reduction in this inequality in our countries? Thank you, Pablo. This is a very relevant topic as we've discussed. The pandemic has led to an exacerbation in poverty and inequality, And we're starting to see that inflation and the high cost of food products and energy products is affecting the most vulnerable populations in a disproportionate way. And so in this case, I think that the issue of social responsibility is very important. So we need to look at what public policy and in particular fiscal policy can do to improve the redistribution of income. This is one of the objectives of fiscal policy, but in the LAC region, the governments are not very efficient in this particular task. Now, we've seen that actions that are taken by the government, in these actions, the best and most effective tools to achieve these objectives is greater investment in health and education. By investing more in the health and education sectors, we can ensure that the more impoverished families, the most vulnerable populations can actually achieve some progress. Many of these people pay more into the system than the services or benefits that they get from the same system that they're paying into. So we need to improve the quality in the coverage. We need to improve the quality of these public services that are provided for the general population. When we do public opinion polls, the worst rated service from the government is generally considered to be the health sector. And this is based on public opinion polls. When we talk about the fragmentation of the system, we need to try to address the labor status of people so that even people who are unemployed can still have access to healthcare services, expanding coverage to vulnerable populations and vulnerable locations, remote locations. We need to incorporate the gender issue. People could be more easily persuaded to pay more into a public health system if it was more effective. And many times families are relegated to conditions of poverty because some health incident in the home can basically cost so much that it destroys their economic capacity to continue living. So all of these elements are extremely important for us to move forward with this topic in Latin America. Thank you, Marta. I'd like to pose some questions both to our panelists as well as our presenters. Perhaps I could ask a question that on the one hand, we could get Krishna's and Andres regarding Dr. Rubenstein's remarks about the linearity or the direct relationship between expenditures and the improvements. And I'm wondering if the estimates or the projections for expenditures or the recomposition of the health sector after the pandemic, will this have repercussions in the long term? Is this something that will eventually converge into something that we would find desirable?
Bueno, pues no, pues muchas gracias a Marta y Adolfo por la respuesta.
Thank you to Marta for her answer. I could perhaps address the question of linearity, and Krishna can talk about the impacts from the pandemic. We explored the linearity issue extensively because we started to see decreasing rates. The capacity to go from 80 to 90 clearly requires a greater cost than going from 50 to 60, because the closer you get to the ceiling, the more money you have to invest. We did explore that hypothesis, but we didn't really find any non-linearities that were statistically significant that would allow us to model that change in the linearity. Now, I think there's also another important issue that's addressed in the report, and that is that given how difficult it is to identify this effective coverage, it's even more difficult to measure it. So since it's so hard to measure it, it's a lot harder to forecast the behavior of this. And this is a call to improve the quality of data related to effective coverage. And given the empirical data that we were able to obtain, that was the best projection that we would come up with. But an increase in the quality of the data could allow us to do better forecasting for these systems.
I believe Krishna wants to address the pandemic question.
All right, thank you. I think the question about the effect of the pandemic on health expenditures is an important one. And when we were going through this study, we were acutely aware that if we did not account for it in some way, our results would be much less believable. So one of the things that we did was for the pandemic years, and you would notice that our forecasting includes some of the pandemic years, we turned the contribution of economic growth to health expenditures to be zero if it was negative or in countries that had experienced a steep decline in economic growth during that year. So that's one way we try to incorporate this. But I think the larger question that was posed was how does this pandemic affect future health spending? So in the small way, we've tried to incorporate the effect of the pandemic, but I think it is really anybody's guess how these sort of shocks can affect health spending. And I would also say it's not just the pandemic, but if you take the war in Ukraine right now, that is going to have also important effects. And so there are many factors like this, I think, related inflation that many countries are experiencing now, that can affect the projections that we have. But what we hope through these projections is to give a flavor of where things are going, and what we might do to prevent the sort of foreseeable future that we would expect if things went that way. Thank you.
Thank you very much, Professor Rao. Muy bien, una pregunta que me gustaría hacer.
One question that I would like to pose to Adolfo is that in terms of the policies that are being proposed to strengthen primary care services, how does this fit with the emphasis on addressing chronic diseases to try to reduce future expenditures? Thank you, Pablo. I think that it fits perfectly because one of the things that we really need to address when we talk about chronic diseases is the vertical nature of the parameter. We look at different risk factors for cardiovascular diseases, diabetes, or cancer. What we need to do is change this horizontal approach. I think that there's a tremendous contribution in the reorganization of health systems and services, and the basis should be the family healthcare teams and primary healthcare teams, and many countries are pretty far advanced in this regard, and they've improved their management systems, but they need a program base that will allow countries to address in a more systematic way all the issues related with the chronic diseases. 80% of these could be treated at the primary care level, and you could leave the higher levels of attention to more complex conditions. So I think that a system focused on primary care, which is one that has been adopted in many countries in the region, such as Cuba or Costa Rica, and other countries, Chile, who have been moving forward with this, and Brazil and Argentina. For this reason, I think it's important that this become part of the agenda in terms of changing the existing systems. I think that the real answer lies in that space more than any other space. Thank you, Adolfo. We're short on time, but Marta, one last question for you. We see that in several countries with more advanced economies, they're going to be spending anywhere from 8 to 10% of GDP on health. And in other parts of Latin America, that will be much lower. In addition to improving quality, do we need to recognize that that's a level that we need to get to and that we need to try to organize ourselves, as you were stating, to look for funding sources, to make the necessary investments in health that will be necessary for us to meet the healthcare services that the populations all over the region have? Thank you, Pablo. As I stated, the current resources are insufficient, and in that regard, the GDP for a country needs to be greater. If it's going to be up to 8 or 6 to 8, then something needs to happen. Some of the more advanced economies have been very effective in their cost containment mechanisms, and there are many efficiencies that can be achieved in more advanced economies. But what's clear is that some countries, a very large share of the population doesn't have any coverage. Even some of the populations that do have coverage don't have access to quality services. This is something that permeates throughout the region. Thirdly, I think it is possible to do something about these inefficiencies and achieve some measure of control of inflation in the health sector, which was something that was implicitly mentioned by Krishna. I think that inflation is much greater in the health sector than in other sectors in the economy. So I think that we need to move forward in parallel fashion. We need to increase or attempt to increase the weight of the allocation for the health sector and do that to address the growing current health expenditures. But we need to address this across all sectors, but not only in the health sector, but in other sectors outside of the health sector. If we don't start looking for and finding other sources of revenue, it'll be very difficult to invest the amounts that are required. Well, thank you very much, Marta. I have just enough time to thank our guests and our panelists for this fascinating discussion. I think we discussed important subject areas such as efficiencies, how to achieve universal health care coverage, and the distinction between effective coverage versus nominal coverage. We need effective coverage that is equitable as well as accessible. And the model that was worked by the Johns Hopkins team is available online, and it will be available for download. We have included the link to that model in the chat room. It's an important tool for us to address policies, and it will allow you to examine how your country can improve efficiencies in some chronic disease cases, such as hypertension or others. And it's an important study that can serve to inform the development of public policy. And I'd like to invite you all to the next upcoming event, Going Beyond Normal, Challenges for Healthcare in Latin America and the Caribbean. And this will be scheduled on Tuesday, May 24th from 2 to 3 p.m. Eastern Standard Time, Washington, D.C. And we will be discussing how services in the healthcare sector were affected by COVID and what needs to be done in the future to achieve better results in the health sector in the post-COVID era. Once again, thank you to all of our participants, our panelists, and our guests.